Keto is not one product or one promise. In medicine, ketogenic dietary therapy is a structured, monitored treatment used especially for drug-resistant epilepsy. Online, keto often means a self-directed weight loss pattern built around very low carbohydrate intake. Those two worlds overlap in physiology, but not in supervision, goals, or evidence standards. If we blur them, a hospital protocol starts sounding like a grocery trend, and a grocery trend starts borrowing the credibility of a treatment plan.
So when viewers hear, keto burns fat instead of sugar, is that a useful summary or a marketing shortcut? And if someone is not treating epilepsy, cancer, or a rare metabolic condition, what should they expect from the diet in ordinary body weight terms? I'm trying to separate the honest fuel change from the internet implication that ketosis itself guarantees visible fat loss.
The physiology is real. When carbohydrate stays very low, liver glycogen falls, insulin levels usually drop, and the liver increases production of ketone bodies, such as beta-hydroxybutyrate. The brain, muscle, and other tissues can use more ketones for energy. But that is substrate switching, not magic subtraction of stored fat independent of total energy intake. The body is changing which fuels circulate and which enzymes are emphasized, while the long-term fat mass results still depends on intake, expenditure, adherence, and the person's baseline metabolism. In randomized trials where ketogenic diets were compared with higher carbohydrate diets under similar prescribed energy conditions, the pooled difference was small, about 1.49 kilograms more weight loss. The certainty was low, the studies were mostly short, and when protein matching was stricter, the estimate became imprecise. That is a possible edge, not a transformation guarantee. It also means a person who dislikes the diet should not feel they are abandoning the only scientifically serious route to weight loss.
If the average weight difference is that modest, why do some people swear keto is the first plan that ever worked for them? Is the benefit the ketones themselves, the appetite change, better glucose swings, or just that the rules remove a lot of snack foods? Because a strict rule can feel biological when it mainly changes the food environment.
The bright line is medical keto. Children with drug-resistant epilepsy, people using ketogenic therapy for neurological disease, and patients attempting it during cancer care need clinician-led protocols. That means baseline assessment, dietitian planning, supplements when needed, monitoring for constipation, stones, growth issues in children, lipids, and decisions about stopping safely. This is not just eat fewer carbs. It is medical nutrition therapy with monitoring because the diet is powerful enough to help and powerful enough to cause problems.
For the non-epilepsy adult, who is the most plausible fit? Someone with high triglycerides and high blood sugar? Someone with obesity-related low testosterone? Or is it really anyone who wants a faster number on the scale? I'm asking because WORKs can mean weight, HbA1c, triglycerides, waist size, medication reduction, or simply liking the plan enough to continue.
The metabolic pattern is mixed but coherent. Reviews report reductions in body weight, fasting glucose, HbA1c, triglycerides, and systolic blood pressure. HDL often rises. The issue is that LDL cholesterol and total cholesterol can also rise. So keto can make one part of a cardiometabolic panel look better while another part moves the wrong way. That is why the baseline matters. A person with high triglycerides and normal LDL is not the same decision as someone whose LDL is already very high. Macronutrient labels hide food quality. A keto pattern based on fish, olive oil, nuts, low-starch vegetables, and unsweetened dairy is not the same exposure as processed meats, butter-heavy meals, and almost no fiber. Plant-based low-carbohydrate trials suggest metabolic improvements are possible, but long-term feasibility and sustainability evidence remain limited. The diet's carbohydrate ceiling does not answer questions about sodium, fiber, saturated fat, micronutrients, or whether someone can eat this way in ordinary life.
What about products that claim to make keto easy? Keto cookies, exogenous ketones, MCT powders, and net carb labels. Should people treat those like tools, or like a warning that the diet has become a branded snack aisle. If a packaged food keeps the keto badge but adds calories, sugar, alcohols, and a lot of saturated fat, the label feels less like physiology and more like marketing.
Raising blood ketones is a biomarker, not a finish line. In a small study of chronically ketogenic male athletes, adding 1,3-butadiene with carbohydrate increased beta-hydroxybutyrate, but did not improve a cycling time trial. The sample was tiny, so is not the final word, but it is a good reminder. Higher ketones do not automatically mean better performance. The same logic applies to weight and symptoms. A meter reading is interesting only if the outcome you care about improves. Medication is the place to slow down. People using insulin, sulfonylureas, blood pressure medicines, or SGLT2 inhibitors need medical guidance before major carbohydrate restriction, because glucose and blood pressure can fall quickly. Ketoacidosis is different from nutritional ketosis, but the risk becomes clinically relevant in diabetes, illness, dehydration, pregnancy, and certain medications. A safer plan is not try keto and see. It is adjust the plan with the clinician who manages the drug that keto may suddenly make too strong or too risky.
Cancer claims make me nervous. If a glioma patient sees keto described as starving tumors, what is the responsible translation? Is it a treatment, an add-on being studied, or simply too uncertain to put beside surgery, radiation, and chemotherapy? I want the answer to protect hope without letting a metabolism story outrank actual survival data.
A practical trial should define success before it starts. Track weight trend, waist, hunger, energy, constipation, sleep, training quality, glucose if relevant, and a lipid panel after the body adapts. If the only win is a week 1 water drop, or LDL jumps while adherence feels miserable, expectations should change. The best diet is not the one with the most dramatic first week. It is the one producing durable outcomes without turning meals, labs, or social life into a chronic stress test.
Who should pause before trying it at all? I'm thinking about pregnancy, a history of eating disorders, kidney stones, very high LDL, diabetes medications, endurance athletes in season, and anyone who turns food rules into anxiety. Are those fair stop signs? And would you add that children should not be put on keto casually just because adults are debating weight loss online?
Those are fair stop signs. Keto is a therapeutic tool in specific settings and a possible short-term weight loss strategy for selected adults. It is not a universal wellness shortcut. The fair test is not whether ketosis sounds advanced. It is whether this person, with this baseline risk, can get better outcomes than with a less restrictive, high-quality eating pattern. If keto improves the right outcomes and stays safe, it may be useful. If it mainly creates restriction, lab trade-offs, or fear of ordinary foods, the evidence does not require loyalty to it.